My name is Chris Markham, and I'm the chair of the Ontario Chronic Disease Prevention Alliance. The Ontario Chronic Disease Prevention Alliance is a collective voice on chronic disease prevention policy and programming, representing over 25 organizations who are operating in the province of Ontario. I want to welcome everyone today who is joining us both in person and online to the OCDPA's first panel discussion event entitled Where's Mental Health in Chronic Disease Prevention? Today we are looking forward to being joined by nearly 150 registrants from across the province, including those from public health units, community health, not-for-profit organizations, and health associations, including the Public Health Agency of Canada and OCDPA members. Before we get started, there are a number of ways for participants to connect to today's events, and I'm going to go through those very quickly. The first is in person, and we have a number of people who are joining us at 33 Russell Street. We also have an opportunity to welcome those who are joining us through live streaming technology. This allows participants to watch and listen to the panel in real time via computer. It requires a Flash player and a Facebook account to log in with, as well as allows for questions to be asked and make comments using Twitter. If at any point the live streaming stalls, please connect with Adobe Connect in the teleconference line. We also have Twitter up and running with respect to this forum. So questions and comments can be submitted via Twitter through the hashtag #OCDPA Series throughout the panel session by all participants. Through Adobe Connect, participants will be asked to use the chat function as at designated points during the presentation for questions and comments. We will have no audio. Adobe Connect participants need to call into the teleconferencing line in order to hear the panel. And we will be taking notes in the discussion section to assist the hearing impaired. From a teleconferencing perspective, the lines will be muted and unmuted at times when participants are asked to respond to questions or provide comments. Finally, as with respect to troubleshooting, if people are experiencing technical difficulties throughout the presentation, I'm told they are to email Zarzinga, and let me provide her email. It's zpal@ontario.cmha.ca. And I will just ask that people keep in mind that this is the first forum that we are putting on, and for the first time, there are a number of technologies that we are using, so we appreciate your patience, and we look forward to working with you to help us improve these systems as we try them out. So before we jump into things, I'm going to start off by, again, thanking the participants for joining us today. You are part of an inaugural event. This is the first panel discussion in a lineup of discussions that form the OCDPA Preventing Chronic Disease in Ontario Panel Discussion Series. As such, you're the first to experience the collaborative efforts of the OCDPA to bring you relevant and critical information and discussion on chronic disease prevention in Ontario, including the leading researchers and research in the field. Each panel will focus on one of 5 OCDPA evidence-informed messages. Today we're talking about mental health. On November 29th, we'll be talking about high-risk alcohol consumption. On January 30th, about comprehensive tobacco control programs. On March 18th, about healthy eating, and on May the 24th, about active living and physical activity. Each panel discussion will aim to initiate discussion on 3 main questions. Marianne will go over these in just a moment. And the focus of the panel discussions is to explore what action is currently underway and what still needs to happen in order to adequately and effectively address these key chronic disease prevention risk factor areas. The dialogue that begins at each panel discussion will continue and will inform in our event, Preventing Chronic Disease Prevention in Ontario, what will it take, where we bring everything together. And that will take place in the spring and summer of 2013. Compared to other major chronic disease risk factor areas, including alcohol use, unhealthy eating, physical inactivity, and tobacco use, mental health is not as well understood as a chronic disease risk factor area. Recognizing this, the Ontario Chronic Disease Prevention Alliance has contributed to the system dialogue through a number of different vehicles that I'm going to go through quickly. In February 2009, the Chronic Disease Prevention Alliance put on a think tank with respect to mental health and chronic disease prevention, with a focus on moving forward as a system. This event was funded in part by the Ministry of Health Promotion through the Ontario Stroke Strategy. It brought together over 50 organizations and really looked at a number of different things, including how we might enhance the capacity of chronic disease prevention systems through mental health, how we might integrate mental health promotion into current and future work, and how we might identify opportunities for collaboration. This document and the proceedings from that event are available on the OCDPA website. In April of 2010, we developed evidence-informed key messages promoting positive mental health. This focuses on things like mental health and chronic disease prevention, health-related consequences, prevalence, cost, reasons for action, call to action, as well as evidence to support the OCDPA's message. Again, this document is available on the OCDPA website. Finally, the OCDPA had produced a toolkit for healthy communities influencing public health policies. Again, this is available on our website. This was developed in 2011. Essentially, this toolkit allows and guides users to develop policy at a local level, providing a step-by-step outline of the policy development process, practical worksheets to help move through the steps, helpful tips, policy ideas, as well as links to other sources of information. So those are three key things that the OCDPA has done with respect to mental health, and today is another really good example of how we look to move this forward on the agenda. The next thing that I would like to quickly show, and then we will move forward on to the panel, is one of the other really interesting things that the OCDPA does is incubate collaborative partnerships between various members. So we have a video we would like to show that is a good example of how a couple of the key partners and organizations within the OCDPA work together to look at some of the factors that influence mental health and environments that support youth to attain optimal mental health and well-being. So this collaborative effort was a partnership between CAMH, the Canadian Mental Health Association, Ontario Lung Association, and OFIA. So I'm going to play that for you now. And Sarah, I know you just told me how to do this.
That's great. Click on video.
That's it.
Yeah. Click on video, and then maximize the screen once it pops up.
Growing up in today's world comes with many opportunities and great experiences. Growing up also comes with many changes and can mean more stress at school, home, work, and in relationships. Dealing with changes and stress can contribute to mental health challenges. Feeling stressed out and experiencing other mental health challenges are
So again, that's one example of a really good partnership that took place with respect to some OCDPA partners to be able to move the agenda forward. At this point, I would like to introduce Marianne Kobus-Matthews, who is a Senior Health Promotion Consultant with KMH, and she will begin the process to facilitate the panel. So thank you.
Thank you, Chris, and welcome to all. The last couple of weeks or so, I've been saying it feels a bit like a canary in the mine shaft in terms of pulling all of this together so that we could make this event as accessible as possible. We have a tremendous program ahead of us, so I'm really pleased to see that we have people in the room, but we also have a lot of participants participating virtually. So welcome to all. And I just want to remind people of the other mantra that a lot of us in the field use, and that is quoting the World Health Organization, that there is no health without mental health. Mental health and physical health are intimately connected through a variety of complex bidirectional mechanisms. For example, depression, anxiety, social isolation, and a lack of social support are significant risk factors for cardiovascular disease, stroke, diabetes, and cancer. Conversely, cardiovascular disease and cancer can increase the risk of depression. The good news in all this, though, is that there's a growing body of literature showing that promoting positive mental health may significantly improve physical health outcomes. As Chris has indicated, OCDPA has and continues to explore the complex interrelationship between mental and physical health within the context of a system-wide approach to chronic disease prevention, which brings us today's panel discussion. Where's mental health in chronic disease prevention? Well, as the title implies, this session will focus specifically on mental health with the objective of increasing our understanding of the dynamic interrelationship between physical health and mental health, as well as identifying current and arising opportunities to take collaborative action in Ontario. So the slide that you see before you talks about today's objectives. To set the stage for what we hope will be an interactive 2 hours, we are privileged to have Dr. Rohan Ganguli lay the groundwork in his keynote address that underscores the fundamental link between physical health and mental health. Following Dr. Ganguli, we are pleased to have 3 esteemed panelists who will briefly highlight current national, provincial, and local initiatives related to the work their organizations do to make the link between physical and mental health. Having heard from our expert speakers, we will then turn to you for your questions, comments, insights, plus responses to 3 general questions that will be asked at each of the OCDPA panel discussions. The responses will ultimately contribute to the summative dialogue that will prioritize actions stemming from all of the discussion panels. We will also identify ways to stay connected and involved after this panel discussion has ended, just before Chris brings the session to a close. So it gives me great pleasure to introduce our very first speaker, our keynote speaker, Dr. Rohan Ganguli. Now I'm going to highlight his affiliations and accomplishments, but I'm going to encourage you to visit the OCDPA website to read his full biography, which will be posted shortly alongside of his presentation. Dr. Rohan Ganguli is Professor of Psychiatry and Canada Research Chair at the University of Toronto, Senior Scientist at the Centre for Addiction and Mental Health, and Professor at the Dalla Lana School of Public Health. He is also Adjunct Professor of Psychiatry at the University of Pittsburgh in the United States. Dr. Ganguli's career over the last 33 years has focused on the development of treatment programs and services for individuals experiencing serious mental illness. Most recently, he has focused on developing treatment strategies to address premature mortality associated with serious mental illness by diminishing the severity of risk factors for cardiovascular disease and diabetes in this population. So without further ado, I'll ask Dr. Rohan Ganguli to come up to the podium. Thank you.
Thank you. Thank you very much, Marianne, and thank you to OCDPA for inviting me to give this keynote address, and thank you to everybody who's here at 33 Russell Street, as well as all the people that we imagine or hoping are out there somewhere in the ether participating in this session. Now, as Marianne explained to you, she said that I'm a psychiatrist, so that's basically what I do for a living, is serve people who have more serious mental illness. And then, as Marianne said, my interest has been in managing and preventing chronic, non-psychiatric chronic diseases in people who have mental illness. Not very good? Okay. A little better. All right. Oh, okay. Are you sure I'm that tall? I don't think so. All right. So, so one of the dangers when you get alleged experts is that they think that they know everything. I actually have the opposite problem. Is that every day, as I learn more and more, I'm impressed by how much we do not know and how much more we need to know and how much better we need to get in our abilities to help people who come to us for help than the other way around. So the more I learn, the more I know that we don't know. And so in this talk, I will focus, I'll warn you, as much on what we don't know as on what we do know. Because I think that hopefully the message is not one of nihilism, but one of encouragement to put more effort, more resources into developing better and better ways of helping people to be healthy. And so the first thing I'll talk about a little bit is about prevention, because prevention is in the title of this particular session. I'm very interested in some of the sessions on nutrition and physical activity, because obviously that again is part and parcel of my daily of what I do again for a living, both clinically and in research. Okay, so now when we think of prevention, there are different types of prevention, and it's good because sometimes when you're trying to refine what you're doing, it's good to be able to put it into a certain framework. And so primary prevention, of course, is kind of the fundamental idea of prevention is that we prevent things from happening at all, so that a disease just doesn't occur. And when you think about this, for example, polio is a disease that we pretty much have succeeded in preventing. Certainly in the wealthier countries, it's almost non-existent. And it was mentioned that I still have an appointment in the University of Pittsburgh, because that's where I spent 30 years my life, and I in fact still live there. And every day I would walk past this sign, which commemorates the accomplishments of Dr. Salk when he was in Pittsburgh. He had the vaccine, and he tried it out on himself, his wife, and his 3 children. So first, well, he didn't really try it out first on them. He did all sorts of things before that. But before, he said, look, bring your children and have them all immunized. He was able to say that my wife, and my 4 children have in fact taken the vaccine, and we all know. And smallpox, for example, has been eradicated from the entire world thanks to vaccines. So this is primary prevention at its best. in almost everything that I do and most physicians, healthcare workers do, we are not doing very much of primary prevention for the types of things that we do. So secondary prevention really is the early diagnosis, so early intervention programs, working with college students around risky behaviors and so on. These are all ways of quickly getting to a problem and interrupting the course of that into the development of disease. And and then there is tertiary prevention, which is really trying to minimize the disability, disablement, loss of function, loss of quality of life associated with having a chronic disease. Because a lot of chronic diseases, we're able to manage them, but they still have very significant impacts on folks. So whether it's a mental illness which is chronic, or whether it's a physical illness which is chronic, and it's the people I work with actually have both, because that's what I mostly do. And then there's this concept of quaternary. How many people, well, I can't obviously ask the majority of people out there, but how many people here know about quaternary prevention? It's a really relatively newer concept, but actually it's an extremely important one. And that is, it is avoiding unnecessary interventions within the healthcare system. And believe it or not, as I said, the more we learn, among the things that we learn is that sometimes some of the things we do are not just unnecessary, which could involve cost and therefore takes resources out of the system, which could be better employed, but may actually cause harm. And maybe during the discussion, if people want, right now I won't take up time talking about this, but it's like making diagnoses that are unnecessary, giving treatments that don't work but have side effects and things like that. But we can talk more about that down the road if people are really interested in that concept. And there's another sort of framework in which you can think about prevention, and that is the level of risk that's involved. And so at the top we have really high risk, which is very complex. So you have a person with complex bipolar illness, it's very treatment resistant. They also have multiple physical problems, and they've also got liver failure from heavy alcohol consumption early on, and the care is very complex at that level. And then at the lowest level, you have things which are related perhaps to small changes that we're not sick at the moment, we don't have any illness or disability, but there's small changes that could be made which can in fact improve our chances. And the reason that this framework is helpful, and I noticed that there's a misprint there, that the bottom says level 1, which actually should say level 4, and maybe I can correct that for what you send out subsequent to this session. Is that the amount of professional involvement, the amount of resources which is at the top of the pyramid is much greater for the high complexity. But the number of people, you see the base of the pyramid is very wide. So the number of people who are who are candidates for,
Keep on talking.
can I keep going? Okay. Who are candidates for the lower level interventions, if you want, if I can use that word, really is much greater, much larger. And the opportunities for self-management are also much greater at that lower level of prevention than at the higher levels of prevention. So we need less professional and expert translates into expensive intervention at the top and more widespread intervention at the bottom. So this slide just lists different targets within the mental health field. Fortunately, in mental health, we have nothing like the polio vaccine or the smallpox vaccine or even the flu vaccine. Unfortunately, we have not yet got to that stage. It is still, it's far and away the prize that we are all striving for. But that doesn't mean we can't do anything. There's lots of things we can do to improve quality of life, improve the course of disease, to promote health and wellness, and that one is obviously the one I'm in greatest danger of spending a lot of time on, because that's what I do. This is just to remind you that we live, the world is really flat now, and we can't just look at our own little corner of the globe. You know, the burden of chronic disease really falls mostly on places that are less well off than we are. Okay, so now I'm going to take a few examples, and I can only take a few because of the time, and I don't want to disrespect the panelists by going on for too long. So let's take an example. We'll take an example of diabetes. This is something that I have several research projects currently going on, one funded by the Canadian Diabetes Association. And so we look at here, there is clearly, they have a page which has diabetes and your emotions, and I'm sure you probably can't see it, but on the left-hand side down there, if you look at one of the links that you can click, it has actually diabetes and depression. So let's talk about diabetes and depression. So there's several meta-analyses. I've just given you two on this slide that have been done, which look at populations of people with diabetes. And again, the bottom line is that if you look at a population, if you look at people who have diabetes, you find that the rates of depression in people who have diabetes is at least twice as much as in people who don't have diabetes. And if you suppose you look at it the other way around, if you look at people who have depression and who don't yet have diabetes, again, I've given you two meta-analyses, not individual studies, where if you follow people out, you find that the rates are, 1.5 or 1 3/4 higher for people who have depression to subsequently develop diabetes. So there's a relationship quite clearly between depression and diabetes, and there are various mechanisms. Again, I won't go into this. If people have specific questions, we can go back to these, and then the slides will come to you for you to read and think about and maybe research if you are interested in that. Now, in life we deal with anecdotes. All of our lives are a series of anecdotes, right? And when I do clinical work, it's every day there are anecdotes. People are coming in, they're telling me about themselves, and I view people in that way. However, it's important not to generalize too widely from individual anecdotes. And so, like this cartoon illustrates how someone can always find an exception. You can always find an anecdote which is an exception. Oh, my grandmother, she smoked a pack and a half a day, and she lived to be 92, and she was healthy to the very end. And, or somebody escaped from the car because they weren't wearing their seatbelts. So switching now to, so that was really a lead into why we need to do studies. Okay, so I'm a researcher, and obviously, I have to declare conflict of interest here. I mean, my job is to do research, but I think it's useful. So here was a study done in primary care in which the question was, if we integrate the management of depression and diabetes in people who have both conditions, can we improve their adherence to treatment? Okay, simple. And you'd say, oh, well, of course, but I don't know, let's see. Well, so the answer is here. This is the slide shows you adherence. Okay, so on the very left, you have the two groups, the groups that's getting integrated care and the groups that's getting just what's standardly done in primary care. And you find there's no difference in the two groups. And then as you go out to 6 weeks and 12 weeks, you can see that the group that's getting integrated care, and the top graph is people who, is their adherence to their diabetes medication. Okay, so you can see that the adherence to diabetes medication is much greater, and then the adherence to depression medication is much greater. And if you look at how many people achieved control, you can see twice as many people who were getting the integrated treatment had control of their diabetes, and twice as many people had recovery from their depression. So not only did their adherence increase, but in fact the integrated. So now this is now evidence that that in primary care, you're more likely to get adherence to your treatment and to get the results that you're desiring, which is recovery from the illness, with the integrated as opposed to the others. Okay, so all of these I pretty much covered, except for the last one, which is when we look a little more broadly at away from that, those were clinically diagnosed depression, we actually have less data than we would like to have, and less data than we need in order to be able to make policy judgments. Okay, thank you. Did I do good on time?
Thank you, Dr. Ganguli. That was very good. Really appreciate it. You have laid the groundwork. And it was really interesting as I was listening to you, you really struck a chord in terms of knowing that we have a fair amount of information already in research, but there's still a long way to go. And we'll be addressing that as one of the key questions for researchers out there. What are the next action steps that we need to take? So I'm going to move us along, but just before I introduce the panelists, I would like to contextualize their presentations. OCDPA released a document in 2006, Thinking Like a System, the Way Forward to Prevent Chronic Disease in Ontario. It sets out a model for a province-wide system that enables effective, coordinated planning, delivery and continuous improvement of health promotion and chronic disease prevention, and interventions at a population level. There were 6 elements that were identified, and that is the what of chronic disease prevention associated with communities of practice. And they're outlined in the document that you will find on the OCDPA website. In addition to that, there were 3 cross-cutting processes, the how of chronic disease prevention, which are essential to system support, and they're also identified. So what we asked our panel presenters to do is to take into consideration these 3 processes as they relate to the work their organization does to make the link between physical and mental health. So the first cross-cutting process is planning and coordination, integrated planning and coordination of activities to reduce inefficiencies and increase effectiveness. The second is knowledge exchange, a broad range of activities required to encourage researchers and decision makers to work together to create and share information, establish research dissemination processes, and support the use of research-based evidence. The third is advocacy, to ensure adequate resources, programs, and policies for chronic disease prevention, locally, provincially, and nationally. So again, for more details, I would encourage you to go on to the OCDPA website and take a look at Thinking Like a System. But now it gives me great pleasure to introduce our panel presenters. And I'm going to once again remind people that they can go on the OCDPA website for their full biographies as well as their presentations. And I'm going to introduce them all first, and then I will ask Michelle to come up first. So our first presenter is Michelle Gold, who is Senior Director of Policy and Planning at the Canadian Mental Health Association, Ontario. She provides provincial leadership in the areas of public policy and system planning. She works in many provincial alliances and networks to foster collaboration and integrate new ways of working to promote mental health and support people with mental illnesses. She is experienced in intersectoral collaboration and fostering whole-of-government approaches. CMHA Ontario is a charity as well as an association to 32 community mental health branches in Ontario. Dr. Renee Lyons holds the first Bridgepoint Chair in Complex Chronic Disease, the University of Toronto and Bridgepoint Health, and is the TD Scientific Director of the Collaboratory for Research and Innovation, Bridgepoint Health. The focus of the Bridgepoint Chair in Complex Chronic Disease is the development of a leading-edge research program in complex chronic disease and support of its multi-institutional collaborations on research development and use. She is a professor in the Dalla Lana School of Public Health and the Institute of Health Policy, Management and Evaluation at the University of Toronto. And Dr. Lyons is also an adjunct faculty member at Dalhousie University, where she held a Tier 1 Canada Research Chair in Health Promotion and was a senior scientist at the Atlantic Health Promotion Research Center. Dr. Lyons' research has focused on chronic disease prevention, health systems improvement, and knowledge translation. Lastly, we have Amanda Sloan-White. And Amanda is a policy and research analyst at the Mental Health Commission of Canada and a PhD candidate in health geography at the University of Victoria. Amanda contributes to several commission projects that work to better understand the links between mental health and chronic disease, including a systematic review project that was initiated in partnership with the Public Health Agency of Canada, the Canadian Institute of Health Information, and the Conference Board of Canada. Amanda contributes to several of the Commission's projects focused on child and youth mental health and collaborative health care, and her research interests include using geographic methods and tools to enhance mental health care and planning in Canada. So without further ado, I'm going to ask Michelle to come to the podium and provide our first presentation. Thank you.
Hi, thank you. I'm happy to be here. Can everybody hear me okay? Okay, I've been at CMHA Ontario for 7 years, and when I came, I was already familiar with Ontario's new chronic disease prevention and management framework. It actually hadn't even been released, but some work I was doing in my previous job, I'd been an author on a report making the case for an integrated approach to looking at chronic disease prevention and management in Ontario. When I came, I and the staff, the policy staff, and I'm going to be talking at the provincial level, we started saying, where's mental health and chronic disease prevention? So today's session, to me, is a culmination of work that's going on, and I would say we're at the tipping point now where there's a lot going on, and the question isn't where it is, but let's get going on it. So I wanted to start by displaying Ontario's chronic disease prevention and management framework. I hope most of you are familiar with it. It comes from the McCall Institute. That was the original framework. It was created in 1996, and in 2003 British Columbia was the first province to say, well, this looks like it makes sense, but what they did is they added to it. And the original US framework was more focused on creating healthcare teams, self-management, information systems, and provider decision support systems. And what BC did was they said, let's put the Ottawa Charter for Health Promotion in it. And that's what you see on the left: healthy public policy, supportive environments, and community actions. You recognize those are three of the strategies from the Ottawa Charter. And that really changed up the game, I think, in terms of let's talk about promotion and prevention. And so the idea was that if you could also work outside of the healthcare teams, but in the broader community, you'd start focusing on population health. And through these productive interactions, you'd eventually achieve improved clinical, functional, and population health outcomes. And so I believe that there's no reason why mental health can't fit into this framework. We don't have to change it. We don't have to create something new. What we need to do is we need to have a comprehensive approach. And I think there's a fair amount of information already from what we've already done with chronic physical conditions to bring it forward for addressing mental health as well. So really briefly now, the three relationships that or the three associations that we know are that people with chronic physical conditions are at risk of developing poor mental health. Poor mental health is a risk factor for chronic physical conditions. And the third one is a little bit different, but it relates to our keynote, which is people with serious mental illnesses are at increased risk for chronic physical conditions because they're a high-risk population. And it sort of reminds me of, because I was involved with some of the chronic disease prevention work about a decade ago. At one time you had each of the disease-specific organizations working in isolation around prevention. And then in 2001, I believe, the Chronic Disease Prevention Alliance of Canada said, well, let's work together on these modifiable risk factors. They're common. And you started to have people come together rather than work in isolation. And over time, it's evolved, and in Ontario, the Alliance has been, I think, really at the forefront of saying it's not just about lifestyle factors. We all know it's about the social determinants of health, it's about population health, and that we've got to work together. And I would argue and make the point to you that mental health fits in this perfectly, and there's no reason to digress. We just need to give it the attention that it's due. So using some of the language that we've already talked about and using the framework, you can see that when we take action to enhance protective factors and we reduce risk factors for chronic conditions, we can reduce poor mental health given the association. So how do we do that? It's the things that we know by fostering supportive environments. For example, if you can improve the built environment, you can promote mixed land use, have green spaces, public places, lighting, which creates safe environments, so there's walkable neighborhoods. Well, not only does it promote physical activity, but it encourages social interaction, and it increases a resident's sense of belonging because these factors are in place. Similarly, community action. The second bullet point. When you create the conditions for civic engagement, you can promote mental health because you're enhancing self-esteem that comes from working together to address a problem, learning about an issue, or gaining new skills. Also with healthy public policy, formulating legislation to deal with income support, for example. It gives you foods, what we could now call food security, which is having the money to buy healthy foods. And when we don't have the money, our mental health suffers. So that's primary prevention. And then we also can look at it from the point of view of mental health promotion. When we promote mental health, which is really, again, another avenue for primary prevention, we can reduce the incidence of chronic physical conditions. And what we know is that there's 3 key determinants of mental health. This is from Kelleher and Armstrong, and they are access to economic resources, social inclusion, and freedom from violence and discrimination. So when you think about it, if you don't have access to economic resources, it can result in poverty and material deprivation, and sustained hardship creates poor mental health. While access to economic resources such as housing and employment provide individuals not just with a sense of socioeconomic status, but social connections. Same with social inclusion. It can enhance a sense of belonging. And lastly, violence and discrimination, like bullying and factors like that, create poor mental health. People aren't confident, and it also affects their ability to take action physically. Lastly, when we talk about it for people that are at high risk, when we take action to promote mental health of people with serious mental illnesses, we can also reduce the incidence of chronic conditions. And this is what the keynote was talking about a bit. Due to factors like metabolic syndrome and other factors, people with serious mental illnesses have a higher risk of, for example, diabetes and things, but they can also benefit from mental health promotion. And this is something that some people may be familiar with, the 2 continuum model of mental health, and some might not be, but most people, when they see it, it's like an aha moment. And that's because mental health promotion benefits everybody, including people with serious mental illnesses. So if you look at this model on the horizontal continuum, you have people with serious mental illnesses who are experiencing symptoms, and on the left you have no symptoms, even though you may have a mental illness, and this is often a period of recovery for people. Then you can have optimal mental health or poor mental health. And when you think about it, for example, quadrant 2, which is the top right, would be people have symptoms of mental illness, but they still experience good mental health. They're coping, they have social supports. Conversely, you can, in quadrant 4, people do not have a serious mental illness, but they're still distressed, they're not coping, and they're not doing very well. So the point is that mental health promotion can support everyone, and it can have an impact then because of the association on reducing physical chronic conditions. So moving beyond a focus on primary prevention, there's also secondary prevention. And so for people that may have poor mental health as a result of chronic physical conditions, there's many things that can be done, we know already. Enhancing mental health literacy, which of individuals and those that care about them, is to increase their knowledge and options when a mental health concern arises. Reducing the stigma associated with mental illnesses so that people will seek care earlier. Also, increasing self-help and support groups for people with chronic conditions can improve their mental health. The relationships continue to go, the associations back and forward, and of course, improving earlier identification of depression in people with chronic conditions is very important. Then in addition, for at-risk, high-risk populations like people with serious mental illnesses, we need to improve access to primary health care. Often people with serious mental illnesses don't have access, and so their physical conditions are not treated early enough. And also, there is a recognized stigma at times by some. Marianne's giving me the sign, I've got to speed it up. Not finished yet, 2 more minutes. I was going to say the stigma, some healthcare providers do have some stigma, and it impacts people's ability to be diagnosed if they have a serious mental illness, and the word that's often used is diagnostic overshadowing when at times, not everybody, but at times healthcare providers may be dismissive of physical health concerns because somebody has already a serious mental illness. So where's the mental health and chronic disease prevention? There's a lot already known. The relationships I'm talking about are things that are in the literature already. We also know from health system providers that are working in the field, either they're aware or they have, anecdotally, they know that there's a relationship between mental health and chronic physical conditions. I would say there's opportunities in the framework to be involved with this. And Marianne, you sort of took my thunder because I wanted to talk about the OCDPA document. I think this is a really important document. It came out in 2006. It says we need to think like a system. And what did it say? I wanted to go into it. This is the important part, I think. It says we still lack in Ontario provincially a coordinated plan to address chronic disease prevention, that the social determinants of health significantly contribute to the incidence of chronic conditions, and I would say also to mental health conditions, and so it's this interplay of these two relationships again. We need coordinated planning, delivery, and quality improvement, both at a health promotion and a prevention level to make a difference. And so here are the 6 essential elements in thinking like a system: build capacity, identify best practices, conduct research, track and monitor, including surveillance, evaluate programs, and develop policies and act through planning. And the 3 cross-cutting themes are coordinated planning and action, knowledge exchange, and advocacy. So I just wanted to end by saying that the second document, I think Chris brought this up, was OCDPA partnered with CAMH and CMHA Ontario in 2009. We have the Ontario framework. We have the Thinking Like the System document. We said, what about mental health? And there were 3 priority recommendations in this document. And I think we need to pull them forward. We know what we need to do. We just need to do it. The 3 priorities that were identified at this think tank were establish a common direction for integrating mental health promotion and chronic disease prevention in Ontario, influence what was then the provincial mental health and addiction strategy, which is in development to include a focus on chronic disease prevention and management. The mental health and addiction strategy has come out. It includes a focus on earlier identification of depression and anxiety. The focus is on primary health care. Although the first 3 years are focused on children and youth, so we're looking for that to be continued to be picked up. But this is not unique to chronic disease prevention. This is something that's an ongoing area for work. And the third area is identify and document evidence-based initiatives for broader uptake. So my main message to you again is that I think the Alliance has done tremendous work to say not only what, but how. We need to pick it up now. I think we're at the tipping point. I think that there's a lot of goodwill, and I think it can happen now. And I just wanted to share with you some resources. My organization, as well as all these other organizations, they're all involved with elements of looking at mental health and physical health with a focus at some level on chronic disease prevention. Thank you.
I think one of the tasks I really hate the most in moderating panels is actually being the timekeeper, because I become so engaged and listening so intently that all of a sudden it's, oh, what's the time? I have to, okay, put up the warning sign. So I apologize. I could have listened to you much longer than that. We are going to hold off on the questions until all of our presenters have spoken, and then we're going to engage in a larger discussion. So it now gives me great pleasure to ask Dr. Renee Lyons to come to the podium. Thank you.
Thanks very much, and thanks for inviting me, and good afternoon, everyone. I was just thinking that if you look at the title of my presentation, a couple of keywords are the piece related to chronic disease management and the piece related to prevention. And as I become older, and as I guess I've wound my way through various types of experiences, both as a researcher and in the area of chronic disease, both prevention and management, I see that a number of these terms are very much interconnected, that I know for our fancy models and our definitions of prevention, they're all kind of separated out. But when you get down to thinking like a system, but actually listening for direction from patients and care providers, you begin to understand that so many of these things are interrelated. And looking at where we should invest and how we should invest in the system is really quite complicated, and but obviously very doable. So what I wanted to do in my presentation was actually take you down to the everyday operation of a healthcare facility that actually works with people with chronic health issues, to look at what we've done in terms of trying to understand our own population, what our patients and staff say to us about what's needed in terms of mental health. Then going a little bit to maybe some of core issues in our society that are contributing to some of these issues, and then thinking like a system again, going back to maybe where and how we move forward. So I work in an area called complex chronic disease, and basically these are people who are often the highest cost to the system. We think of them as the highest burden in terms of healthcare delivery, as well as family burden, and often people who have many health issues, physical and mental health issues, often have very high care needs, and often are carrying healthcare issues over a long time. So if you think of often the older adult population, as we age, we have more chronic diseases, but also we see a lot of people in the younger age groups that are living and going to be living with a lot of chronic disease burden over many, many years. So who are they, and how do we deal with them in terms of the system, and at the same time try to prevent as much of this as possible? At the Collaboratory, what we've been trying to do is take a very different approach to research, because our sort of people are the people that most researchers run away from. These are the people who are often the exclusion criteria for randomized control studies. And so if you look at the evidence base for moving forward, often these are the people who are omitted, even though, in fact, they're the people that probably create the most stress and burden in terms of care delivery. So one of the things that we decided to do, first of all, was just figure out who our people were. And we did a major study with 116 of our patients to find out basically who they are, what they need, how did they get here into the system, and how can our models of care at Bridgepoint Health actually improve care and outcome. And so what we did was we generated a fair amount of data, quantitative data and qualitative data, and we also listened to people as to what they said to us. So in the quantitative data that we had, we actually found a very, very high prevalence of depression among our population, lots of other mental health issues, but I want to really focus pretty much on the area of depression and coping and adaptation. And they talked a lot about the issues of living every day for themselves and their families in terms of dealing with their health issues, and absolute fear about going home and dealing with these issues every day, and self-management. Well, that's a huge issue for these individuals. And just to give you some idea of what they said to us, here's a patient voice. People think it's an easy solution. Medicate someone to the point of not feeling and the problem is solved. Many people could do with talk therapy, and it should be part of a complex, comprehensive rehab program. When you're in a car accident and your body gets broken, you become broken as well. Another patient voice. I hear the same story from people from every walk of life, and that story is that no one is helping them with fear, with emotion, with frustration, with anger, with any type of emotional counseling. And I think that it is important, or even more important in some cases, than whether or not they get Humpty Dumpty into some sort of physical functional way. And so we saw this all the way through our Bridgepoint Health surveys. We developed a model of care in terms of complex chronic disease that puts coping and adaptation and mental health issues really up front and center. And all of our research at Bridgepoint Health, even looking at the effect of our beautiful, if you know Bridgepoint Health, it's gorgeous new healthcare facility we're opening in April, looking at the effect of that healthcare facility, the mental health and coping and adaptation elements are central to understanding even how a physical building should function for our people. We then went ahead, and Amanda, who's sitting over there, was very much involved in leading this, a study on, so what do we think that the clinical staff should have in terms of training and support in dealing with some of the mental health issues of our patients. So we asked 20 key questions. There were 125 respondents, which was, it sounds 11% is an amazing response in a chronic care hospital, and there were 18 different clinical groups represented. Again, overall, what we heard was, we are not prepared to deal with the mental health issues of our patients. And we need a lot of support and thinking as to what should be happening if we're going to actually deal with these issues most effectively. And again, it was everything from the basic coping, stress, and adaptation that we're seeing in patients to major mental health issues that we also see in our population. Here are some staff voices. Our patients need help with loss, grief, anger, and our staff need assistance in handling behavioral issues. I feel that mental health is becoming much more prevalent in our complex patients, and it would be beneficial for all staff to increase their knowledge and skill set for this population. In my experiences of working at a hospital setting for over 7 years, I would say we shouldn't forget how much emotional support from family, friends, community, and staff is important for patients with mental health issues. And so in terms of our hospital and some of the things that we need to do to actually ramp up the mental health promotion as well as the management, we need to do a lot of things. We need to think extremely carefully about, so what's the strategy we need to use to embed mental health promotion and treatment within a complex population. And I think if you go right across this province, you'll see that there's not enough being done to think about the mental health side and services. We need skilled staff, We need training. We need research to look at effectiveness and performance, and to have some performance metrics to see, are we actually working effectively? And we need to do some costing to figure out, okay, with all of this work going on in the province about costing, how do we actually embed the cost of both health promotion services and treatment in that process? Let's also then go back to some of the things that we're seeing in our patient population, because we actually asked them to tell us, so how did you get here? And so much of what we were seeing was at the point where they actually needed social resources to help them deal with their health issues, they were actually losing so many of the social, financial resources and supports that would have helped them maybe even prevent some of the complexity that we were seeing. And how can we actually begin to look in a preventative way, and this might be considered secondary prevention, in dealing with the losses. We're just seeing too much preventable complex chronic disease in the system. And some of the work that actually I'd done about 20 years ago, kind of came back to roost. So it just seemed that so much of this had to do with people's difficulty in sustaining and developing adequate social supports and networks. As Michelle was saying, key determinants of health in the model, but we were seeing it so much within our patient population. And we've done like 20 years of work on chronic illness and relationships. We have some tools, some interventions that can be used with individuals and small groups to actually help bolster and support the networks that they have. So, hey, maybe there's an opportunity through all of this initiative to really begin to find places where this work can actually be used. Because within the system, I can tell you, people are too busy dealing with the physical health issues, and they really aren't dedicating enough time to these sorts of things. The other thing just generally is from our work, we see it's not just about healthcare, but it's all the way through upstream, the importance of embedding these ideas right through the system. Obviously, we all believe this, but actually doing it in a substantive way is what we need to do. And the other thing that I thought would be very useful is that we talk about health equity, we talk about access to services. And so could we, in fact, take these ideas and truly look at, so what do we mean about primary access to service? What do we mean by secondary and tertiary as it comes to mental health promotion, and begin to embed in each of these areas some real tangible supports for people to actually deal with some of these issues. So thank you very much.
Thank you so much, Renee. I was just about to hold up the 1-minute card, and you beat me to it. And all of a sudden, I'm racing around. For those people who are joining us virtually, I have to tell you that I'm having to race around behind a number of tables, jump over a number of cables. There's the alliteration or the whatever, and then to make it here. So when you ended early, and I was so engrossed once again in what our speakers are saying. So thank you. I'm now going to turn it over to our third speaker, Amanda, and I will be that much more cognizant of making sure that I'm a little closer to the podium when you're coming to an end. Thank you.
Thank you. So, hi everybody. Hello. And thank you so much for having me here today. It's just wonderful. So today we're going to kind of have a slight departure from the last presentation. We're going to move it from kind of the health provider level up a little bit to more of a systems level again. And today I'm going to be talking about chronic disease and mental health and outlining some of the reasons why we think that there needs to be attention to this issue and the methods that we use within the Commission for Knowledge Exchange, which may be helpful for you in your work moving forward. So the Mental Health Commission was created by the federal government in 2007 with support from all levels of government. And the mission of the Mental Health Commission is to promote mental health in Canada and really to work with our stakeholders to change the attitudes among Canadians towards mental health issues and to improve services and supports throughout Canada. At the Mental Health Commission, we envision a Canadian society that values and promotes and helps people who live with mental health problems lead meaningful and productive lives. So to that end, the work of the Commission over the past 5 years has really worked to promote the vision that good health has to include both mental health and physical health. Physical health is affected by your mental health, as the previous presenters have noted, and likewise our mental health is of course affected by our physical health. So having good mental health improves physical health outcomes, as we've previously heard as well as your economic participation and your social relationships. Really, we can't have a healthy Canada unless we have Canadians that are mentally healthy and physically healthy. It has to be both. So the complex relationship between chronic disease and mental health really encourages us to think holistically about health across the system and at the individual level. So the medical system has been typically organized around specific diseases or organs, such as the kidney in this comic. And I find this kind of funny because we hear this a lot. So in this comic, the consumer or the patient thinks that his doctor sees him really as a kidney, but he's more than a kidney. He's a person, and he has a heart, and he has a brain, and he has many other different organs, but really his doctor just sees him as that because that's his specialty. But in order to address the many factors that impact chronic disease development and mental health, we really need to reconceptualize the healthcare system and really are thinking about health away from these kind of siloed disease types into a more holistic approach. And this will work to prevent illness wherever we can. So just to recap again, as the previous presenters have noted, the importance of focusing on chronic disease and mental health is really shown in the findings of a vast number of research studies that have shown that having one disease increases your risk of having another. So it's really like a domino effect. You could think of it that way. So for example, having a mental illness increases your risk of physical health issues like metabolic syndrome, heart attack, and hypertension, as we've heard already. And having a physical illness also increases your risk of mental illness like depression, which is highly linked to diabetes. And so again, the research on the prevalence of concurrent mental health issues and physical illness, they're really quite startling when you get down to those studies. And they do emphasize this strong relationship and really why we need to focus on this at a national, at a provincial, and at a local level. So just one example here, a Quebec study found that 31% of persons that had heart attack in their study had mild to moderate symptoms of depression. And this is significantly more than among the general population. It does give us some perspective of how startling the prevalence of these concurrent disorders really are. Now, these trends have had an impact on healthcare spending and utilization in Canada. So overall, the research has shown us that having a physical illness and a mental health issue really acts as a cost escalator that increases the cost to the system to treat these diseases. So one study found that treating diabetes for persons with depression was almost 5 times higher than just treating somebody who had diabetes but did not have depression. However, despite these trends, we also know that persons with mental health issues are disproportionately, they have low rates of preventative screening and treatment for chronic conditions. So what happens is that chronic conditions can go undiagnosed for quite some time until they become really acute, and then persons end up in the emergency department and as inpatients in hospitals, which we know is very expensive to the system. So improving preventative screening and treatment for chronic conditions among this population really could do a lot in addressing some of the major concerns that we have with healthcare reform right now in this country. So as we've heard already as well, the promising practices and the work that we do at the Commission is really threefold. So we do target primary prevention as well as secondary prevention and treatment services. And we really need to address all three of these aspects in order to make a difference within the system and among Canadians. When we often think about chronic conditions, we often think of older Canadians or seniors. And I'd just like to highlight here that research shows us, and the approach of the Commission has really been to take a life course approach to this issue. So this includes investing in primary and secondary intervention programs, and of course treatment for young Canadians, so those under 25, who are really at risk for developing mental health issues within that age, as well as related physical health issues. Actively managing chronic conditions at this young age will do a lot to prevent illness in the years to come. So when young Canadians today become 65, hopefully we'd see a reduction in the rates of, say, diabetes, cancer, or heart disease. And in fact, investing in child and youth mental health could really pay the biggest dividends in terms of reducing rates of chronic illnesses, and we really get the bang for our healthcare dollar when we invest in child and youth mental health in this country. So I'm now going to highlight some of the recommendations that we have through the national strategy, as well as our seniors guidelines for comprehensive mental health services. So the mental health strategy for Canada that was recently released this past spring really recommends that we do encourage the early diagnosis of mental health issues and substance use problems. And they particularly highlight in the strategy that we need to focus on persons with chronic physical health problems because they are the most at risk. They really are a risk population, and we need to focus on this area. We also have the guidelines for seniors mental health services, which recommends that we promote good mental health through existing services, and that we really leverage opportunities. We already have opportunities within the system that we could use to make a difference. And these include using rehabilitation programs, pain management programs, and exercise groups, and leveraging those opportunities to improve mental health among seniors. So in terms of treatment, the strategy also highlighted a number of recommendations that are important to treating comorbid mental and physical illness. So we need to improve timely access to services, and this is particularly for persons with mental illness who we know have difficulty obtaining basic diagnostic tests compared to the regular Canadian. And what this would do is work to prevent hospitalizations as well as inpatient treatment, which I've said can be quite costly. The strategy also recommends that we need to have increased collaboration in our primary care environments, and so, for example, family health teams. And we also need to leverage opportunities with diabetes educators, case managers, and other healthcare providers across the system. So now, kind of moving to the knowledge exchange work that we're doing within the Commission. This definition is the definition that we use for knowledge exchange for our work, and it comes from the Canadian Institutes for Health Research. And we like it because it speaks to the collaborative process that we think needs to happen for knowledge exchange to really be effective across the system. So our model of knowledge exchange involves multiple stakeholders. It includes those that we usually think of when we think of KE, and that is policymakers, researchers, and providers, but we also really highlight caregivers, and we highlight persons with lived experience and youth. We believe it's not really enough to involve these individuals at the end of your research project or your policy implementation, but that we need to bring them in from the onset to really form the initiative from the get-go. Within our knowledge exchange work, we emphasize that all voices need to be treated equally. One perspective is not better than the other. They're all important and really have equal importance to transforming the system. So this is the guide that we use at the Commission is called the Innovation and Implementation Guide for Knowledge Exchange. And if you'd like more information on this, you can certainly contact me or go on the Commission's website. This is really a how-to guide for designing knowledge exchange activities. So if you'd like more information, please let me know. And so finally, just to wrap up here, we know there's a strong relationship between chronic disease and mental health, and this really emphasized that we need a holistic approach here to prevent illness as well as the severity of symptoms. There is an economic argument here to be made for improved prevention, promotion, and treatment in this area. And we do have frameworks like the recently released Mental Health Strategy for Canada that really does emphasize physical health. Even though it is a mental health strategy, it does reference physical health and it is there. And moving forward, we need to leverage opportunities for knowledge exchange among mental health related organizations, but also our chronic disease partners. So thank you.
Thank you, Amanda, and I'd like to thank all of our presenters, but ask them not to go away. Don't you move, because this is the point of the program where we're going to engage in discussion based upon 3 questions that are being asked at all the panel discussions that are being hosted by OCDPA over the next little while. And this will allow us to, we've mentioned the seminal document that OCDPA put out, Thinking Like a System. Well, now we can start making that transition to envisioning ourselves acting like a system. And hopefully, these 3 questions that we'll be asking will jettison us into thinking or acting like a system. So we are going to turn it over to you. And as we've already indicated, there are various ways for people to participate in this discussion. Okay. So, you see before you the very first question. What are the main action steps needed within the next 1 to 2 years? And you will see that there are a list of players, if you will, that can be identified within that question and what action steps we feel that they should take. And this is, again, I want to emphasize that this is one of the 3 questions that will be asked throughout the panel presentations in the future. We do have participation coming from across the province. So here's how I envision this next little bit. I'm hoping technologically that I get it right. We're going to ask people in the room first, because we'll do this on a rotating basis. We'll ask people in the room if anyone has a question. Then we will go to the teleconference, the people who are on teleconference. I will open up the line to see if there is a question there. And then we will move to our technical colleagues who may have questions coming in via Twitter or Adobe Connect, etc. And again, they could be questions, they could be comments, etc. So I would like you to think about how you see the action steps that are needed for the next 1 to 2 years, whether it's for government, whether it's for the Ontario Chronic Disease Prevention Alliance, whether it is for researchers, and what are your thoughts in terms of individual organizations. You may also have a question that relates to the material that has been provided that has given us groundwork in answering some of this. So I'm now going to ask our the people in the room if anyone has a question, and if you'd please come to the mic. There may be a reluctant group here.
Marianne, can I just it's really just a point of clarification. Are you asking us if we have questions in terms of what are the action steps, or are you asking us if we have other questions that might just pertain to the panelists or in general?
I would say it's a combination of the two. So, and I apologize if I wasn't clear about that. People may have questions related to the material that they have heard, or the material that they have heard may lead them into thinking about what could those action steps be for the next 1 or 2 years, whether it's for government. And we heard Michelle addressing some of those ideas, whether it's for OCDPA, whether it's researchers, and we certainly have researchers galore here that could respond to those questions, or individual organizations as well. So I am going to, if there aren't any questions in the room, I'm now going to, looking at my colleague Tamar, I'm now going to press *2 to open up the teleconference line to see if anybody there has a question. And I'm doing this upside down.
Participant lines unmuted.
So the lines are unmuted, and I'd just like to remind people that background noise can be heard, so if you can be aware of that. Do we have any questions via the teleconference? If so, could you just give us your name and where you're from and your question? Or your thoughts around what we could be doing in the next 1 or 2 years? And feel free to make comments as well. Okay, I suspect that people are always worried about the first one to speak. What I would like to encourage is the second person to come forward to speak. And we'll dispense with that first person.
Can we just do a sound check to make sure there are people on the line? Can someone just say hello?
Hello.
Thank you.
So the person who said hello.
That was a trick.
Well, I don't want to say that it was a trick, but now that I'm thinking about it. The person who has said hello, brave person that you are, might you have a comment from what you've heard, or might you have something to contribute to our thinking around some of the main action steps that are needed in the next year or two?
I don't have a comment. I mean, I don't have a question or a comment to put forth. I'll just say thank you very much for putting on this session, because it's been helpful.
Oh, I'm so very pleased, and I'm very pleased that our presenters have done such a stellar job. So thank you for your comment. I will keep the line open for another couple of seconds if the third person now would like to come online and ask that question, or ask a question or make a comment. Okay, I'm going to mute the lines again, and I'm going to turn to some of the comments or the questions that may have come in through other means. So here we go.
Participant lines muted.
Good.
So we have a question from somebody.
Could you perhaps come up? This is Arsanga, who's one of our colleagues from CMHA Ontario. And if you can ask the question, Arsanga.
So the question is, what processes are in place to align referral systems that could help people living with mental health challenges?
Can you repeat that one more time?
What processes are in place to align referral systems that could help people living with mental health challenges?
So, Michelle, would you like to respond? We have a pod here. If you would like to, well, that's on the teleconference line, or if you would like to actually come up here and respond to the question.
Is this on? Can people hear me? I don't know if it's on.
I think one of the initiatives that has gone on the last maybe 6 or 7 years with the new investments in community mental health has been the creation of primary health care access that is for people that historically have not been able to have it. So I know that in Ontario, the community mental health agencies, many of them are either have taken on relationships as a satellite community health center. They may have nurse practitioners. They may have physicians or even psychiatrists on staff, and that has created more availability as well as increased access. In addition, there's a lot more collaboration than there was in the past, and so community mental health agencies are often either co-locating or collaborating in terms of service agreements with primary care practices or family health teams, because there's historically been a bit of hesitation to take on more complex cases. So because of that, there's been some movement. And I hope that answers the question about what processes are in place. Do we need more? Yes. The other thing is there's always the dialogue in Ontario about reducing avoidable emergency room visits. And oftentimes what we need is we need better processes for when people show up in the emergency room. I was mentioning diagnostic overshadowing before, that people are receiving care for what they need and that they're referred out to access continuing primary care. And even then, a lot of the hospitals have taken on community-based discharge planning to try and get more comprehensive ways to refer people who are coming into hospital that maybe didn't need it if they had better access in the community. So there's been some inroads, I think some significant inroads in Ontario, but more needs to happen, and we need to have a situation where I think more primary healthcare providers feel prepared to deal with what are more challenging or complex cases that are then seen in primary care.
And I think Rohan.
Yes, so this is Rohan Ganguli. So I do want to say something about primary care. So actually, the majority of people with chronic disease don't have complex chronic disease. There's always like the pyramid is, the base of the pyramid is the widest. And so the majority of people with depression and diabetes are actually not in a complex setting. They're being dealt with in primary care. And Ontario actually is doing stuff about this, So there has been efforts to educate primary care physicians and primary care providers, physicians and others. But I want to make a special mention about family health teams, because family health teams actually are a very deliberate mechanism in which structurally the collaboration in care has been built in structurally, both through the requirement that it's an interdisciplinary team. So a large enough, well-functioning family health team has a whole lot of healthcare providers, which include social worker, psychiatrist coming in, and the various primary care providers, nurses and physicians and so on, pharmacists. So structurally it's set up to actually provide that integrated care, which in at least one of the slides I showed you improves the outcomes of both the chronic mental illness and the chronic physical illness. The other thing that is built in the family health team is the compensation model. So as opposed to traditional family health care, so Canada has a good, of all the countries, it really has a very good and very extensive primary care system. But the problem had been that you had a fee-for-service system which encouraged or rewarded, let's say, and if you reward things, you basically encourage people to do them. The amount of service or the numbers of services delivered as opposed to doing it in the optimal fashion. And the family health team is financially a different model in which the funding is based on a roster. So it's a capitated model in which the health of a population of people is what your income is indexed to, or the income of all the providers. So so in fact Ontario, I think, is further along this than many other places that I've been to.
Thank you. It has been suggested that we ask the panelists how they might respond to question number 1 as well. What are your thoughts around what the main actions, sure, forgive my back, what are the main action steps needed for the next 1 to 2 years for these particular players and from your perspective? And while I give you a moment to think about that, I think we have another question. Okay, so Senga?
So we have a follow-up question online to Michelle's comments. The question is, are family physicians, general practitioners aware of many of these different clinics and these different innovations that are taking place within the community sector?
Can I actually make a comment to that?
Certainly.
A lot of the patients that we see at Bridgepoint Health actually come through family health teams. We do take people with complex chronic health issues, but we have a large collaboratory of people also from primary care who are also saying that the primary care system, even with some of the new innovations, are still having great difficulty dealing effectively with many of the mental health patients with mental health issues as well as chronic disease issues that they're seeing. And if you look at, I just give you an example, many of the models of health delivery still do not embed the complexity within it. So for instance, you can have people with diabetes, and if you look at the traditional education system that's set out there for diabetes education, and then you look at the need in terms of complexity, people with social disparities, people with mental health, and you look at the capability of the diabetes educators to actually deal with some of these complex issues that are directly related to mental health, that obviously the system really is not set up and not funded to actually deal with complexities in the way it actually needs to be. So I will answer your question to say, I think one of the things that we will definitely need to figure out is how, where are the models that are actually working? What is the cost and the requirement where we can take some typologies of the mental health issues that we're actually seeing in the communities? How can we actually take those and begin to look at the actual service delivery system needed, the connection not only just with healthcare, but the connection between social care and healthcare, and to begin to cost out baskets of care that will actually have long-term impacts on some of the individuals that we're seeing.
So you have a question then? Thank you.
This is a question from one of our live stream participants on Ustream, and they were wondering, how do we eradicate stigma when we're, for somebody working in mental health programming, how do you eradicate that stigma? At what levels? What, at different levels, what can you do as an individual and as an organization and research?
Can I ask the panelists Amanda, would you like to respond?
Sure. So one of the primary ways to eradicate or combat stigma is through education and kind of myth busting. So in the past year, we've really seen some large private and public sector investments in stigma kind of busting campaigns. One example of that is Partners for Mental Health, which just launched their newest campaign to educate youth about mental health and to really get some momentum in mental health reform for children and youth. And then we also have, at the Commission, we have an initiative called Opening Minds, which is working with journalists and other persons, other stakeholders to really, through education, talk about how stigma is perpetuated in the media and how we can better report on these issues. But primarily education is how you do it, and really kind of myth busting some of the common thoughts or public perceptions about mental health. Because the statistics really speak in terms of, say, violence and mental health. It's not necessarily as related as the media tells us. So.
Any other questions from Oh, we have one. Chris has a question.
Hi, just a quick question. I'm wondering if we can follow up, because it's come up a couple of different times with respect to sort of evidence or research-informed programs. And last week, I was at a session, a summit on children's mental health. And one of the researchers talked about that they did a scan across Canada, and there were literally hundreds and hundreds of programs that address mental health as specific to children. One of the big issues that was raised at that point, it's been noted a number of different times this morning, which I find really, really interesting, is the evidence base behind those programs. And generally, the discussion went on that there is no evidence. And there is a lot of programming that is being introduced, in this case, into the education system that has very, very little evidence associated with it. And I'm wondering if we can go back to the original point that was raised by Dr. Rohan with respect to maybe this fourth area in terms of it getting confusing, both for, let's say, educators, public health, others that are looking for something that is evidence-based and will make a difference.
This is Rohan Ganguli again. So thank you for that question. So I think that what you say is absolutely correct, which is that there is relatively little evidence for most of what we do. I mean, I say this as a clinician, like I'm confronted every day with, there are people in front of me, patients, caregivers, and so you have to do something. And I think that that's the stage we're at with a lot of, just to throw up your hand, say that, okay, there's no evidence, so, sorry, you've come to the wrong door, is not going to be very helpful either. So I don't, I think that we could quickly rush, and unfortunately policymakers might well say that, look, we're not going to pay for all of this because, look what the experts are telling us is there's no evidence. But there is also at the same time that there is, I think, I feel a compelling need then to evaluate the things that we are doing. That is, if we have to do something. You can't do nothing, so you're doing something. But if you're doing something, then you must be evaluating it. And this is true as we go along, because there are things that we have evidence for, but they don't work for everybody, right? And so even when we are doing things that are very evidence-based treatment, I give an antipsychotic to somebody, who has schizophrenia or bipolar disorder, there are people who don't respond to it, right? And I think that I'd be much better off, and that person, more importantly, would be much better off if I knew who would respond and who would not respond to the treatment, so that, remember, in quaternary prevention, we can at least spare the people who won't respond to treatment from having all the costs, meaning costs not just in money, but costs in physical and mental suffering of getting a treatment which is not going to work for them.
I think the issue of evidence is an important issue, and first of all, we need an inventory of some of the more promising interventions that are going on, but there's different kinds of evidence for different kinds of interventions. And so in a clinical setting, you might want to do a randomized controlled trial, but when you're starting to talk about continuity of care and more sort of complex interacting systems, which is part of the model too, we need to come up with different kinds of approaches. And I think that one of the things that funders could do is start to support the evaluation of these initiatives, and not only the evaluation, but there's a lot of infrastructure required, like foundational items. What are the indicators? Who's going to do the evaluation? When new programs are funded, they're often funded on a shoestring, or agencies have a good idea, or clinicians, because it seems to make sense, or they try it. But let's sort of get it to the next place. Then there's population health ones, and maybe while I'm up here, I could speak to what needs to happen. I think when we do have best practices or some idea of what's effective, we need to see if we can replicate it and measure. But we also need to set some targets, routine targets, and so then we get into I think things like what would be indicators and targets at a population level. And I really just wanted to mention Act Now, which is an interesting program in BC that was not around mental health, but was around physical health. The program's very interesting. It's been evaluated by the World Health Organization. And what they did is they set some targets before the Olympics were in Vancouver on a few key indicators, and one was smoking, and I think another one was physical activity. And there's pros and cons to self-reported data, but it's sort of like the Canadian Community Health Survey. There is population-level data, and if you start to set some targets, then you need to have a strategy in place. And what they did in BC is they had a whole-of-government approach, and they had a champion that was high up in the government. And so what do we need to do next? We need to evaluate promising interventions. We need to report them and share them, and that's knowledge prevention. Sorry, not prevention, knowledge translation. And then the other thing we do is we need to set some targets to get started on other things, and I think that would make a huge difference. And that's something that maybe others can advocate for, but the government would need to, I think, be involved with what we could do in terms of mental health, and we have population health data.
We have two more questions that we were going to get through, but our agenda has been very ambitious, and it's clear that there are a lot of thoughts, and we want to take full advantage of our expert panel here. So what I'm going to suggest is that each panelist, to put you on the spot of course, if you wouldn't mind giving us your summary thoughts on the priorities we need to focus in on, the challenges, and how we might address those challenges. And here's the real challenge, is that we'd like you to keep it to 1 to 2 minutes each. Let's not make it really difficult. Let's make it really, really difficult. So, and I know that in each of your comments, you've started to seed what we should be thinking about in terms of actions, etc. But can you give us your summary thoughts? Because regrettably, we are running out of time, but we'd like to take full advantage of the expertise. I'll also ask too, because we've had somebody comment that they're having problems hearing. So if you can speak loudly into the microphone, that would be terrific as well. Again, we want to take full advantage of your expertise. So would somebody like to start by giving a summary of their thoughts, please? Thank you.
I don't mean to hijack the agenda, but I'm actually going to take your question, take Michelle's comment, and to also try to embed some continuity in the line of thinking. So if we're actually looking at developing a good set of evidence-informed approaches to say, where do we invest? What's actually really effective for what population? There are a couple of thoughts here that I think would be very useful. The thing about the Act Now that I think is extremely useful, the BC Act Now, too, I was on the Michael Smith Foundation Advisory Committee for that, so I was living it morning, noon, and night as to how to actually do a complex intervention on about $25 million worth of intervention studies. And from that, there are some excellent guidelines with really practical ways to actually get the best information from a complex intervention like that, which I think we really need to be able to do and to synthesize and to bring it back to get practical guidance for people on how to actually implement. So I'd highly recommend that as a model. The other thing that just happened recently was the American Geriatric Society looked at the literature on comorbidity and multimorbidity. So these would be people that often have physical health issues as well as mental health issues in primary care. They looked at the evidence for the effectiveness of primary care interventions in these populations and found that, in fact, there was so little evidence that they could not base actions on this. So instead of pretending that there was evidence, they actually said, let's begin to look at promising practices and develop a set of principles to guide service and care. And this seemed to me to be such a sensible approach to actually moving forward. And as the evidence gets directed, then you begin to embed that more effectively. The third thing that I would say, there is a tremendous opportunity for some of the people in mental health and chronic disease management to begin to come together to actually develop some really good systematic projects where we could begin to look at embedding health promotion within chronic disease management. And I can tell you, as a person working in that system, we would so welcome some collaborations to begin to see how we could best do this work. Thank you.
Thank you. So would one of the other presenters care to come up and give some summative comments?
I felt like I spoke. Just
okay.
Maybe you can tell they can't hear me. I just feel like
okay.
Yeah, sure.
Yes?
In terms of the question, what are the main action steps that are needed? In terms of OCDPA, I think it would be very helpful to have the organization identify real priorities in this area. So say 3 to 5 priorities where your efforts would be targeted over the next 5 years or so, because that way other organizations in other provinces and nationally can identify opportunities to work with you to see through those goals so that they're clearly articulated, because there are many complex answers to some of the issues that we've highlighted today, and we need to start unraveling some of that complexity. Similarly, with researchers, I feel I've been at numerous conferences recently, and every time I go to a conference and I hear about chronic disease and mental health, it's more research, more research, more research. And I agree that we need more research, but I would also like to see some priorities from the research community, perhaps in combination with our funding bodies, around chronic disease and mental health nationally. So where are those areas where we really don't have anything, that we really need something immediately, and how do we invest in that? So have researchers that do both youth and seniors mental health from the chronic disease and the mental health sectors across the board come together to coalesce around this issue and identify some priorities that we can act on, because if we don't have priorities, we're all kind of doing different things and we're not necessarily working together where we can. And then in terms of individual organizations, do what you can do to see if there's any opportunities within, say, your practice or within your agency where you can leverage some types of initiatives to work with other agencies, where you can kind of double your efforts and all move in the right direction. So, yeah.
Thank you. Are there any last words at all? Because otherwise I'm going to wrap this piece up. Again, I thank you for sharing your expertise, and I think that as we go through the recording of this session, which will be posted on the OCDPA website, we will be able to parse the action items that we're hearing from you, from the questions, and I might also point out too that we are not only recording this, but my technical colleagues have also been recording the questions that might not have been posed. So we will be taking a look at those, pulling everything together and creating a frequently asked questions document, an FAQ. So let me just quickly tell you how you can stay connected and involved. So visit the OCDPA website and you will find the link to the recording of the panel discussion. I mentioned the FAQs, and that will include those questions that we were not able to get to. We're also developing a newsletter. Some of you, when you registered for this, already indicated that you wanted to subscribe to the newsletter, so you will be getting that. But very shortly, we are going to be putting the newsletter together based upon this panel discussion and the outcomes of the discussions. And as well, we will be posting upcoming panel discussions, etc. You will have an opportunity to continue the dialogue when we send you out the evaluation that will ask you questions about what you think the action steps should be, etc. You can continue that dialogue and keep this conversation going. I think it's being reflected in the comments that we've heard already that we need more discussion around this, but we need to move toward action as well. So on those words, I am now going to pass it over to Chris, who is just going to summarize the afternoon. And thank you all.
I think it's going to be too hard to summarize. I'm going to be quite honest with you on that one. We covered a lot of ground. I think one of the things that really impressed me that the speakers here today have really given us a clear and a consistent message with respect to mental health. Some of the key takeaways include the fact that there is, as most of us already know, a very strong relationship between mental health and other risk factor areas. That there is a need for ongoing research in this area, but there's also enough that we have some sense around what best practices should and continue to be in this area. That we are also reaching a bit of a tipping point. I'm not sure we would have been having these conversations even 5 or 10 years ago. And that we all have a shared responsibility to be able to move this forward, including government, NGOs, alliances like the OCDPA, and a whole host of other partners. So I want to take a moment and I want to thank, first of all, the panelists for taking time from their very, very busy schedules to join us today. So thank you to each one of you. An enormously huge shout out needs to go to the staff who have put together today's event. There's like 15 computers set up over here. I don't understand what's going on, but thank you very much for your time and energy in terms of putting it on. And then I also want to thank in particular sort of our co-sponsors on this, the Centre for Addiction and Mental Health and the Canadian Mental Health Association, who took lead on putting together this panel session. So thank you very much, and I believe that's it. We're going to sign off. Yes, thank you.